Welcome, guys, for our 2023 edition of the Urology FRCS Viva training recordings. And before starting the recording, today we are going to discuss the topics and exam scenarios on benign prostatic hypertrophy. Before heading to the actual scenarios, you both have any questions, anything burning, or anything you want to clarify before the questions? Both of you?
Uh, no.
No? Okay, good. So we'll start the scenario. The time starts now. Good. You have a 48-year-old gentleman presenting with history of a significant difficulty in passing urine. He says that he needs to strain to pass urine and the urine stream is not brilliant. How are you going to evaluate him?
I would like to see him in my Lux clinic, along with a bladder diary, a completed IPSS, and a urine dipstick test. I would take a focused history and a detailed examination, focusing particularly on his symptoms regarding the onset and duration. I would clarify regarding his storage and voiding symptoms, of which this seems more like a voiding symptoms, so with straining and uh, poor flow. I would also inquire about any mixed symptoms. I would inquire about any red flag features such as visible hematuria, dysuria, weight loss, or recurrent UTI. I would also inquire about this gentleman regarding any bowel symptoms, any constipation, and his average fluid intake during the day, paying particular focus to caffeine intake and carbonated products. I would also inquire about any previous pelvic surgery or radiotherapy and past medical history, including anticoagulations or further comorbidities, or any previous medications or treatments that he's had for his urinary symptoms. I would move on to the examination, and within that, I would calculate a height and weight so that I could calculate a BMI. I would then move on to the abdominal examination, looking for any scars, any masses, and looking otherwise for any evidence of renal disease or stigmata of renal disease. And I would look at his external genitalia and evidence of phimosis or retraction in the external urethral meatus. With verbal consent and a chaperone present, I would carry out a digital rectal examination, feeling for the consistency and the size of his prostate, and also carry out a neurological examination of the lower limbs. And if his bladder is quite full, I would also like to attain a uroflowmetry test with a post-void residual if possible in clinic.
Okay, good. So his symptoms, as I said, was quite bothersome, and he was not full enough to have any uroflowmetry in that hospital visit or clinic visit. Examination wise, he's moderately built. Abdomen and external genitalia were normal. Digital rectal examination showed approximately 60 cc smooth feeling prostate. What will be your next steps?
Um, I would counsel the patient accordingly with regards to what he would want out of his symptoms, which are bothersome. I would say that there are a few options which are available regarding either conservative management, cutting down on his caffeine intake, etc., avoiding excessive water during the night, or medical treatment for his condition, which would be in the form of either an alpha blocker agent or 5 alpha reductase or a combination of both. Um, and certainly, given his prostate size, which is around 60 cc, certain surgical options would be available. Um, Given this gentleman is relatively young, I would probably like to counsel him for alpha blocker treatment initially, and then review his symptoms in 4 to 6 weeks and see how he is getting on.
Okay, any investigations you need to do?
I would like to do the uroflowmetry test to confirm things. I may wish to do a PSA test, given the fact that he is having some dysuria symptoms, and it can help in evaluating further treatment options as per the NICE guidelines.
What is the role for PSA test?
PSA of greater than 1.4 has been shown to have an increased risk of developing acute urinary retention. And so therefore, if his PSA is indeed above this figure, then justification for medical management would be an option for this man.
What is the value? Can you repeat again?
1.4
Okay.
or above.
Yeah. Any other investigations or is it enough?
If I thought that this is pointing towards a neurological symptoms, or there was any mixed symptoms present, and he has previously failed any further treatments, then certainly urodynamic assessment could be appropriate with regards to further planning of treatment.
What do you know about the embryology of prostate development?
So the prostate develops within the mesonephric duct. It has different zones. It has a central zone, which is derived from paramesonephric duct, and it has a peripheral zone and a transition zone, which are derived from the urogenital sinus. It sits just under the bladder, and as over time it increases in terms of hypertrophy of the glandular components of the prostate, which can lead to urinary symptoms.
Okay. In the exam, you may be asked to draw the anatomy of the prostate. Here, you can verbally explain to me if it is asked, what will you do? What is your main crux in the drawing?
I'm sorry, I didn't quite follow that.
In the exam, they may ask you to draw the prostate anatomy in a paper.
Sure.
So if it's here, we can't demonstrate it, but can you explain what you will draw?
So I will draw the different zones of the prostate as delineated by McNeil: peripheral zone, transition zone, central zone, and elements of the transition zone, which will have the prostatic urethra within it, a peripheral zone, which will have,
I'm trying to open a whiteboard. Do you want to draw for me? Is it just give a try? If it's not working, that's fine.
Sure.
I know in exam you can draw this much better than usually with a whiteboard.
So the prostate is here,
Mm-hmm.
and then this is the urethra going through it.
Mm-hmm.
Around the periurethral area will be the transition zone.
Mm-hmm.
Around that, sorry.
That's okay. That's okay. I understand that.
Around that will be the central.
Yeah.
And the outermost would be the peripheral zone with the anterior fibromuscular stroma as well. The central zone would also harbor the ejaculatory ducts and sort of the ejaculatory mechanisms along its path.
Okay, that's good. Now, what do you know about Hall's ring? Hall, H-A-L-D, Hall's ring.
It is a combination of bladder outlet obstruction, lower urinary tract symptoms, and elements of BPH, which can merge within each other and have a component which is contributing to the lower urinary tract symptoms of bladder outlet obstruction.
Okay. What about IPSS score? When you will do, what is the role in the initial evaluation?
So the IPSS score has storage and voiding symptoms or questions. Within the storage symptoms, frequency, urgency, and nocturia are asked, and this is over a period of 4 weeks, and it's out of 5. And the voiding symptoms, of which there are 4, which is weakness in the stream, intermittency, hesitancy, and straining. The scoring is out of 35 with a separate quality of life questionnaire out of 6. And it's calculated according to different values and graded accordingly to the symptoms. Between 0 to 7 is mild, 8 to 19 is moderate, and 20 to 35 is severe. And it's usually a representation of the patient's symptoms over a 4-week period.
Okay, what are the limitations of IPSS scoring?
The limitations are there are 4 components addressing the voiding symptoms and only 3 addressing the storage symptoms. Therefore, it's not representative totally between equal symptom scorings. There can be, it's a very subjective assessment of the patient's reporting. So therefore, it can vary with someone having a very high objectivity of obstruction with very low symptoms, or equally the opposite, with low objectivity of symptoms but low objectivity of obstruction but high symptom score. So it's very subjective in terms of its reporting, but it's very good to use as a reference point for each patient rather than used in isolation within one consultation itself. So it is probably better to use it as a reference point to see how a treatment has benefited a particular patient.
Okay, good. Your time just completed in the midway of the last answer, but as I said, it's better to complete the answer so that it's good for people or revising, etc. Now, a good performance, I think the first time we are discussing, so you may get much more better sleek in the vocabulary and presentation, everything as we go on. Only few things here and there. For example, in the red flag sign, I think it is useful if you include the neurological signs, if at all, if there is anything, and also bedwetting. You said about hematuria, but bedwetting could be sometimes the starting point of finding something like high pressure chronic retention, overflow incontinence, renal failure. The whole thing may head into a different wrong direction. And in urology, especially in patients with urinary symptoms, either male or female, it's nice if your nursing staff can do the blood pressure and heart rate outside. So you can say that when the patient is waiting, my booking nursing staff will do the heart rate and blood pressure, because the increase in blood pressure could be secondary to the renal failure, etc. Most of the clinics do. So if you're doing in your practice, you should say. If not, also it's nice to bring in. Okay. And the other things are like IPSS score. I'm quite surprised that you have not brought it yourself in the initial summary. So bring IPSS quite early in the discussion of the signs and symptoms itself. And the easy way to remember is the moderate symptom IPSS is 8 to 19. So anything less than that is low, anything more than that is severe symptom. That's one way of remembering. Otherwise, I'm happy with the way by which you explained the IPSS, but it's nice if you have brought it in your presentation itself. And as you said, IPSS is not a very brilliant test, especially if it's done at one point, but it's nice to see the trend. I think that's what you're trying to explain. Instead of saying as a reference point, IPSS scoring, the trend will be more useful to see whether the patient is responding to our intervention or not.
Yes.
And yeah, uroflowmetry and frequency volume chart, all those things I think you have done well. Bladder diary, if possible, if it's in a one-stop clinic, you can bring some new latest concepts. As you know, from the GRIFT guidelines, there's a lot of stress on lots of one-stop clinic. And also we have got kind of a clinic setups of faster, efficient, early diagnosis symptoms which are going on. So there is a lot of push towards one-stop clinic. So you can use it for like a patient with increased PSA, one-stop testicular malignancy clinics, one-stop LUTS clinics, and one-stop female urology clinic, etc. So you can bring them. PSA, as you said, that's one of the useful tests. And when you're saying, especially if the examiner is asking, will you do any other test? The examiner is just testing you. So you need to say that no, there is no need for any other blood test. And the blood test, like for example serum creatinine or EGFR, will be useful only if there is any signs of renal failure. Similarly, imaging of upper tract is useful only if there is any signs of renal failure. And you can be a little bit more sleek in embryology. So as I said, usually all these questions are like open book exam. If you get evaluation of male LUTs in the exam, this is the exact question they are going to ask. So embryology, just be comfortable in finishing the whole thing in 3 to 4 sentences. If you just practice, you will be fine. And similarly, the imaging, as I said, is only if there is any signs of renal failure for upper tract imaging. So when the examiner is asking, instead of saying I don't need any further results or imaging, you can bring in your more caliber. As much as possible, you should show to the examiner that you know stuff. That's the main idea of the 10 minutes. And similarly, you can bring in cystoscopy and tell that cystoscopy has a role, especially if there is a previous failed intervention, and in the modern era with multiple minimally invasive surgical treatment options available, cystoscopy will give us a good idea about the prostate's internal anatomy, which will help us to decide which type of minimally invasive treatment patient may be suitable for. Okay?
Sure,
Good.
sure.
Well done. No concerns. Good start. So things should get only better from here. And
Thank you, Mr. Dhanasekaran.
yeah. Let me see if there are anyone online. Yeah, I think the others are online. So the next topic will be on medical management of the LUTS. Who wants to go for it? Both of you?
I'll go for it, Mr. Dhanasekaran, if that's okay with everyone.
Okay, Ali. Yeah, we'll go ahead. Let me switch on the timer. So others can stay muted, please.
Just let you know I've arrived.
Okay, yeah, I saw that. I saw the list. Yeah, thanks, James. And you don't have to use any. We'll try our best not to call by names so that it remains anonymous, and also no need to use the camera. If you want, that's not a problem. Okay, we'll start the scenario now. Your time starts now. The same patient, let's continue. So this patient IPSS score was found to have obstructive voiding pattern, and patient is quite symptomatic. His IPSS score is in the region of 19 with quality of life at 5. And what will be your next steps? You may have heard about this patient. If not, I can summarize you. It's a quite young patient, no medical comorbidities, 49. Examination showed quite large, 60 cc prostate, no neurological findings, no red flag signs. Okay, what is your next steps?
So I will, once he's been assessed, I will discuss the options of medical management, conservative management initially, which my colleague has described earlier. If the patient does not want that or has failed that, I will offer him medical management, and I'll discuss the options of monotherapy with alpha blockers or 5-alpha reductase inhibitors versus combination therapy. His other option is going to be surgical management, but I will give him the trial of conservative management plus medical management first.
Okay, is there any role for urodynamics for this patient? If not, what patients you will prefer to do urodynamics?
So NICE and EAU both do not recommend routine urodynamic studies for patients with LUTS. And this is also supported by the upstream study. Patients who will require urodynamic studies are patients who have had a previous failed surgical management, patients who are young age of 50 or age more than 80, patients who cannot void more than 150 mils, patients who have significant voiding LUTS with a post-void residual of more than 300 mils, or patients with voiding LUTS, significant voiding LUTS with a Qmax of more than 10 mils per second.
Okay, your patient is 48. I'm not sure whether you got the age because you joined late.
I'm very sorry. I will reconsider this, and I will offer him, discuss the offering him urodynamic studies.
Okay, good. So, but a good referral, upstream study. It's nice to know that the role is not that much except for very selective patients. Okay, so you are doing urodynamics for this gentleman. What are all the factors or the outcomes or the results you will be focusing on?
So I would like to look at the patient comfort and subtraction, also patient bladder capacity, any detrusor contractions or detrusor overactivity, patient compliance, contraction, capacity, contraction, compliance, and continence.
Okay. Is there any nomograms available for to help you to find whether the patient needs surgery or any intervention?
There is the Abraham Griffiths bladder outlet obstruction index, which the formula of which is PDET at Qmax minus 2 Qmax. And if it is more than 40, then this is going to be obstructed. 20 to 40 is equivocal, and less than 20 is non-obstructed. There's also the bladder contractility index, the formula of which is PDET at Qmax plus 5 Qmax. And it shows that if the value is more than 150, this means there's strong detrusor contractility. Between 100 and 150 is normal, and less than 100 is weak.
Okay, you will be asked to draw them in the exam. We have tried this whiteboard in the Zoom. It worked okay. You want to give a try? You can draw Abraham Griffiths one. I know it won't be as neat as drawing in a paper, but give a try. Yeah. I think you need to press and draw. Yeah, press. Yeah, exactly. Yeah, that's it.
Okay, this is not very straight.
That's okay. That's okay. Yeah.
And it's going to be.
So what is in the x-axis? What is in the y-axis?
Mr. Dhanasekaran, I'm sorry, I don't remember.
Okay, don't worry. Your diagram is quite good, and the only thing is you should know what is in the x and y axis. So in the x-axis will be Qmax. Qmax will be by ml per second. In the y-axis is the PDET at Qmax, and it will be since we are measuring the pressure, it will be centimeters of water. And as you know, the Abraham Griffiths number, or to be called as bladder outlet obstruction index, it is PDET Qmax minus 2 Qmax. So that's why the lines are parallel to each other and the lines don't reach zero. You have correctly marked it as just above the zero. So the point where it meets just above the zero, that is 20, and the one above that is 40. So anything in this area, so anything in this area, you can see my thing possibly. So anything in this area is obstructed. This is like equivocal, and this is like unobstructed. Okay, don't worry, don't stress yourself. That's fine, we got the message. And similarly, the changes will be for the next one, bladder contractility index. Do you want to give a try?
So bladder contractility index is like this.
Good.
And this is PDET at Qmax.
Yep.
And this is Qmax, which is mils per second.
Yep.
Per second. And this is also going to be mils per second as well. And this is going to be less than. So this is going to be 100. And this is 150.
Okay.
And this is strong contraction, this is normal contraction, this is weak.
Good. So once you know the x and y axis of one parameter, it's both are same. Okay. And y axis PDET by Qmax, PDET into Qmax, and it's a pressure. So the unit is centimeters of water. For Qmax, you know it's ml per second, and your values are correct. It joins at y axis at 100 and 150. So the topmost is strong, then normal, then weak. Good. Well done. And so this patient urodynamically shows presence of obstruction. There is no signs of any other detrusor, lack of compliance or anything like that. So what is your next step?
So I will offer him medical management, which I have mentioned earlier. His other options are going to be surgical options. I will give the patient a patient decision aid and bowels information leaflet for the surgical options that are available to him. I can counsel him regarding the medical options, the combination therapy or monotherapy.
Okay. What do you know about the natural history of BPH?
So the natural history of BPH is that as the patient or the man gets older in age, their prostate increases. The QMX decreases, and I think it was the Garaway study that suggested that BPH of 20 grams plus LUTs or QMAX of less than 15 mils per second with increase of, I think at 40 years of age, there was about 14% of people, between 40 and 49 years of age, 14% of people had this. And at 60 to 69 years of age, about 43% of people had this. So as the men get older, their QMAX decreases.
Okay. Any other study explaining the natural history of BPH untreated?
Sorry,
Okay.
I cannot recall it.
Okay. How will you predict that a patient BPH may progress worse? What are all the parameters for you?
So the parameters is from the Olmsted County study that suggests that patients with who have risk of retention are QMAX of less than 12, prostate volume of more than 30 cc, age 70 to 79 years, IPSS score of moderate to severe, PSA of more than 1.4, and post-void residual of more than 50 cc, 50 mils.
Okay. Your time is complete now. We can stop now. Okay. Good. How do you think you did? I think you did good.
Okay, thank you. I was a bit confused, Mr. Dhanashikan, because I wasn't sure if you wanted me to expand further in the medical management, or would you want me to go to surgical management as well?
Not
Because I was ready
necessary.
with the MTOPS and the combat
Yeah.
plus.
Yeah, that's what. So what actually happens in exam is, I mean, today I've sent all four of you the possible scenarios. So sometimes mentally you may be quite tuned. The first scenario is like evaluation of a patient with LUTS. Second scenario is medical management, but not necessarily that you need to progress. As long as the quality of the discussion is maintained, the examiners will be happy. If you are maintaining quite high quality discussion, you should not be penalized for not progressing, because the ownership is on the examiner to skip some questions, like for example the natural history of BPH progression, everything to take you towards the medical management, to evaluate your knowledge on, as you said, top study and other things. So I don't think you will be penalized for lack of progression, provided the quality of answers are good and there is no wastage of time in between. I don't think you wasted your time any time, and your quality is good. Of course the whiteboard is not brilliant, but at least something is there for us to have some revision. And
Yes.
the not getting that x-axis y-axis correctly during the Abraham Griffiths number is fine. It won't really affect the marks to the level of pulling you to the dangerous level. But these are all, as I usually say, these are all absolutely open book exam. So this is the exact question they are going to ask. So make sure that you are absolutely confident on that. And natural history of BPH, you can bring Olmsted County study also. You brought in Garaway study, and but you brought the Olmsted County study later when I asked about the predictors. There are other studies like Ball et al. And Barry, but don't worry about too much, but try to bring as much of studies as possible in BPH and CA prostate table. Otherwise I'm quite happy. There is no major concerns. And regarding the management, it's definitely medical management. He's only 48. No way we can think about surgical management directly. He has to try the behavior management, he has to try the lifestyle changes and medical management, and we should make sure that the medical management is not working before heading towards surgery. And medical management, maybe we can discuss in the next scenario, then you will get the overall idea. Okay,
Okay.
good. So who is available for the next scenario? Two of you.
I will do the next.
Okay, that's good. So your time starts now. So it's the same patient. We'll continue. So the patient was evaluated, and you know that he has the severe LUTS as per the IPSS, prostate measuring 60 cc, no other comorbidities, quite young, fit, sexually active, 48-year-old. So what is your next step? The investigations like urodynamics proved presence of obstruction, but otherwise flow rate showed a obstructive voiding pattern. Post-void residue is 130 ml, and is quite symptomatic. What is your next step?
So this is a young patient who is severely symptomatic, and so the next option would be starting him on medical treatment. He has tried conservative and that didn't work. So I'll start this patient on alpha blockers and assess his response in 3 months' time with a repeat IPSS, post-void residual, and uroflowmetry, and then see his response to the alpha blocker medication. And then in the next step, then I can consider adding the 5-alpha-reductase inhibitors. Meanwhile, I will also discuss starting both medication at one time as well with the patient. But in my practice, I will start him on alpha blockers.
What are all the advice you will give in lifestyle changes for him?
So I will advise this patient to time his voiding, reduce fluid intake in the evening time, avoid caffeinated drinks, and avoid bladder irritants and avoid constipation. And these lifestyle changes would be helpful in improving his lower urinary tract symptoms.
Is there any role for phytotherapy?
There is no recommendation from EUA and ISO AUA guidelines, but they are used as several are available, but there's no recommendation based upon studies.
Okay, so what is your drug of choice to start for this patient?
So I will start him on tamsulosin 0.4 milligram once a day, explaining the side effects, and that would be my drug of choice for him.
Okay, so how will you explain the side effects?
So I'll tell him that there is a risk of retrograde ejaculation. He has some postural hypertension, which is in less than 10% of the patient, and it happens usually in the initial few days, and it resolves. So whenever he's standing up from the lying or sitting position, he shouldn't do it suddenly, and he should take this medication initially at the night time before he goes to sleep. I'll also explain that he may have some hypertension with this medication, and other than that, if he has some eye surgery planned, then I'll need to inform his ophthalmologist for the floppy iris syndrome as well.
Okay. So between various alpha blockers, do you have anything to choice, or is there any evidence behind your choice of tamsulosin?
The usual evidence is from the studies done on alfuzosin and doxorubicin that were used previously, but alpha-1 tamsulosin is alpha-1 a selective medication, and it is more prostate selective and with limited side effects as opposed to the other medications. And I'm not exactly sure about the evidence for tamsulosin right now.
Okay. Now, which group of patients you will try a combination treatment rather than tamsulosin alone?
So, as per NICE guidelines, if the patient has moderate to severe lower urinary tract symptoms,
any other factors make you to try combination? We can't hear you. I think we have lost him. Oh, he's in online.
Do you want me to continue, boss?
Yeah, please continue.
So your question is, what are the reasons why you will try combination therapy?
Yeah.
So there are various studies that have shown that combination therapy are superior to monotherapy, combination therapy with alpha blockers and 5-alpha-reductase inhibitor. ANTOX study compared doxorubicin versus fenestride and combination monotherapies and combination therapy. and it showed that it was superior in reducing clinical progression of LUTS. Combat study compared Avodart, which is dutasteride, and tamsulosin. And it showed that combination therapy had better outcomes as compared to monotherapy. If the patient has symptoms of urgency or as well, then the patient can be tried with anticholinergics along with combination therapy as well. As per various studies, for example, I'm sorry, the name escapes my mind right now, but we'll let you.
Yeah, we'll come back to that.
Sorry, I'm back. Sorry.
You're back. You're back now? Okay, you can continue now.
Yeah, something happened to my internet now.
Yeah, I can see your mic is on, but somehow, anyway, it happens. Okay, so in your absence, what we have discussed is various evidences available to support the combination treatment. And for our patient, do you think you can try combination treatment?
I don't think so. We can consider it to begin with. So initially, I'll start with, that's why I will start with tamsulosin only. Because he's a young patient, so he would not be tolerating the sexual side effects of the combination treatment and the side effects. Yeah.
Okay, let us discuss something slightly different. A patient comes with a urinary retention. So what kind of medications you will start? Urinary retention is a different scenario, but since we are discussing these medications for lower urinary tract symptoms, what is your choice in a patient with retention medications?
So if someone comes with the retention, and then if it is it's confirmed it's not a high pressure retention, if we're considering TROC, then again we'll start him on alpha blocker. We usually start him on tamsulosin, but the study which we use for considering TROC in next 1 to 3 days is the L4 study, which use alfuzosin. So, but we usually use tamsulosin.
Yeah. Do you know any outcome of the Alford study? Any values, numbers?
So it improved the successful TROC to 30 to 40% in the patient who were more than 65 years of age and post-void residual less than 1 liters. Yeah, these are the values that I can remember.
Okay. And any other publications you aware of regarding which patients will fare better for surgery, which patients will do with medications?
No, I'm not currently aware of that.
Which patients you will go ahead for surgery directly or quickly compared to starting medications? Any features will make you to think, okay, he may need surgery rather than going on with medications?
So the patients who had precipitated, spontaneous acute urinary retention with the large post-void residual volume and deranged renal function would be ideally fit for surgical management rather than trying medications and then go for surgery.
Okay, good. So your time is completed now. We'll stop here. And don't worry if there is any problem with the internet at any time, and somebody will jump in and fill the shoes in the meantime. But the end of the day, you should get the feel of that full 10 minutes. That's what I am trying. Okay, a good presentation. Since the first time we are starting, I'm sure things will go only better from now. And for the indications for surgery, there is a mnemonic RUSHES, RUSHES. R stands for recurrent or refractory urinary retention, U for recurrent UTI, S for bladder stone, H for hematuria, which is refractory to medications, E for elevated creatinine due to bladder outlet obstruction, S for symptoms deterioration despite maximal medical treatment. As you see, when I am sharing this recording, there will be a slide in the background, so that will be quite useful. So don't worry about taking the notes during the sessions. So just pause the slide, pause the video, and then go through the mnemonic so that you will get the theory behind in case if you are missing it. So the mnemonic is RUSHES. And you should bring phytotherapy if possible spontaneously, because sometimes it's nice to see that you are aware of phytotherapy, and there is a Cochrane review which shades that phytotherapy is not useful. So when you discuss the medications, the first thing is behavior or lifestyle modifications. Then quickly say I will not go for phytotherapy due to a Cochrane review advising against it, and then go for the alpha blockers and other discussions. I mean, you can skip phytotherapy, nothing wrong in it, but if you know that phytotherapy, some entity is there and it is proved to be not that successful with a Cochrane review, it's nice to bring those values. There is a good review in BJUI on 2011 on 6,000 men with medical management of LUTS. I will again put that links in the recording so that it's useful for you. Yeah, Alford study is the good study for urinary retention. It's done with alfuzosin, but in practice we tend to take tamsulosin, and that's the rationale behind removing the catheter in second or third day after starting the medications. And if the alpha blockers are continued, the chances of surgery is less. That's the outcome of that. And if untreated, the complications, everything you have discussed well. And yeah, there are lots of other studies you can discuss well. I think Ali has done a good job. The study which Ali is trying to bring, including anticholinergics in a male LUT, is TIMES study, TIMES, which stands for
Times and Neptune 1 and 2.
Yeah, Neptune 1 and 2, yeah. And TIMES stands for treatment of men with low urinary tract symptoms and overactive bladder. So yeah, it's nice to mention studies, especially in BPH and prostate cancer. Somehow they tend to ask again and again. Otherwise, combat study, MTOP study, Ali has brought out very well. Study which supports the finasteride is P less Proskar long-term efficacy and safety study. 5-alpha reductase inhibitors can be discussed. Other than that, I think side effects, everything you have done well. You can bring in NICE guidelines June 2015, because that is the last LUTS guidelines from NICE guidelines. But then NICE has released various small medical technology related guidelines for all the small surgeries or minimally invasive treatments, which possibly we'll discuss in the next scenario. So for LUTS, it is June 2015, almost going to be 10 years, quite outdated. And the one other thing is there is a Bowes information leaflet on LUTS. So it's nice to bring in the Bowes information leaflet. At least you should know that there is a leaflet available. We know the leaflet's available for a lot of procedures, but for male LUTS, we have leaflet available just for the male LUTS alone, so that patient is aware of what they are undergoing. Good. Time to go for the next scenario.
Sorry, one last question. Is there any trial for this indication for surgery?
No, the indications for surgery, again, you can mention the NICE guidelines itself, because it is in the NICE guidelines June 2015, which is mentioned like prostate more than 30 cc, patients with increased residual urine, patients not tolerating the medicines, and patients has no improvement after starting the medicines, all those things. So it's in the NICE June 2015 guidelines. The other thing is, when you are mentioning tamsulosin, try to say it as 400 micrograms rather than 0.4 milligram, because there is a good article to say that these kind of prescription errors can happen if you are putting 0.4 milligram. Somebody may not recognize 0. Of course, tamsulosin comes in only one dose, but it's always nice to have 400 milligram as a good habit. Sometimes if the examiner is very passionate about it, they won't reduce the mark or anything, but it's a good habit even for the life and future. Okay?
Boss, can I just ask a quick question? You asked about when can this patient have combination therapy. I think there is some recommendation from NICE about it.
Yeah, that's what I said, like prostate more than 30 cc, increased PVR. There is a list which we gone through. Yeah.
I think it's the same thing from the Olmsted County. Pretty much they've copied pasted it. It's a PSA more than 1.4, prostate volume more than 30 cc. It's like that.
Yeah, so the Olmsted County is more of BPH progression study. It found these features will make the prostate to progress quickly. These are all like high risk factors, And NICE recognized these factors and said that okay, if there are any high risk factors which may make this BPH to progress faster, why to just treat with only one drug, tamsulosin or alfuzosin, which is not a prostate constricting drug. It's only going to relax the blockers, which results in a bit of a stability. Why can't we add the 5-alpha reductase inhibitors so that the prostate shrinkage also happens, so that we know the patient is going to fare worse, and these are the patients who may require surgery quite early. Okay.
Okay, thank you.
Good. Okay, we have the last candidate waiting, and we are going for surgical treatment of LUTS. Let us continue with the same scenario. The same patient went home with a combination treatment. Maybe there's nothing wrong in saying that he had tamsulosin alone. The only thing favors him not to go for combination treatment is young age. So we don't want the patient to have unnecessary problems of erection or ejaculatory function at the young age. But say if he's not faring well, we will start a combination treatment. And this patient is reviewed say in 3rd month, and also as a follow-up maybe in another 6 months time. Unfortunately, he was not happy, and his symptoms were quite bothersome. What is your next step?
My next step was to see him in clinic, reassess his symptoms, storage, voiding, red flag symptoms. But knowing that he's past all that stage, and I still think this is bladder outflow obstruction, then I'll be considered surgical options. Surgical options can be described from something less invasive but less effective, such as Urolift, Rezum, which is a form of water vapor therapy, to things that stand the test of time, such as transurethral section of prostate, which is our reference operation, and enucleation operations such as the HOLEP operation. Less other operations which are slightly less invasive could be prostatic artery embolization, and then more invasive, although I'm unsure of the number of centers that do this, is open prostatectomies.
Okay, let's assume that this is a real-time patient and the patient is sitting in front of you. He tried tamsulosin and then a combination for another 3-4 months, and he's not happy with that and also suffering from side effects. And just to recollect for you, the patient has become from 48 to 49 when we are following up, and his prostate is 60 cc. So what is your choice? How will you do next?
Okay, so I would ascertain what the side effects particularly. I mean, someone that's quite young, I would suspect the side effects are erectile dysfunction and retrograde ejaculation. With a 60-gram prostate, as per the girth guidelines, most options are available to him, that being Urolift, and if it was appropriately counseled and addressed, particularly median low, Rezum, aquablation, TURP, enucleation as well. And that's all, and also vaporization as per girth guidelines.
Okay, the patient says, doctor, whichever is good, please select and go for it. And he says, you are the expert. So which one you will go for?
I would direct him to, it seems quite young, so the Canada, as per girth guidelines, the Canada Decision Aid, which goes through all the pros and cons and how the procedures are done. If he was looking for less side effects, then you're looking for less invasion, such as Urolift or water Rezum, which have less side effects on erectile dysfunction, as per the LIFT study, looking compared to sham, and BPH6 study, which show there's no change in erectile dysfunction. Prostatic artery embolization also has good effects or less effects on erectile dysfunction. However, as per the ROPE study, there's no long-term evidence, and that's only 2-year evidence. If he does want longevity, although happy to take the side effects of retrograde ejaculation, which is about 90% seen in enucleation, then I recommend HOLEP, which is beginning to become the reference test form of treatment for bladder outflow obstruction.
Okay, so what is your choice? The patient again says that I'm happy with whatever you have discussed. I understand there are a few things I'm eligible for. How will you counsel him for any one of the procedure?
So I think it can also be used in a stepwise manner, ladder approach. So we can start from something less invasive, and if anything changes or things deteriorate, then you could go down to something a bit more invasive, such as the TURP and HOLEP. So I would offer a missed and minimally invasive surgery, such as Urolift,
Okay, so what is Eurolift? What are the constituents?
The constituents are a local anesthetic procedure, a day case. It works by retracting the prostatic lobes laterally, and therefore opening up the channel to make people void better. Pharmacologically, it is a nitinol stent with it's nitinol component of it with a stainless steel urethral plate connected together. The nitinol aspect pierces the capsule, and then the urethral stainless steel compresses the prostate, therefore opening up the channel. And we do that on multiple sides, depending on the morphology of the prostate. And that's also including median lobe. So that does not prevent someone from having a Eurolift procedure as per the MediLift study.
Okay, what type of median lobe is good for Eurolift, and is there any contraindications?
So Eurolift originally it was not used for median lobes. However, with the right people that have been doing it for a while and experienced hands, we know that median lobes can be retracted to one side or another. And as per the MediLift study, that tells that it can happen and it can be done. Similar effects.
Okay. Any other latest evidence you are aware of regarding Eurolift?
The two big studies, so we have a prospective study, which is the BPH6 study, and that was telling us how good it was, comparing it to TURP, although it didn't have the same IPSS and Qmax effects, it did have better quality of life and the impact score, which they use the BPH impact score test. And the other one being the LIFT study, it was first done by 2 years compared to sham. Then recent studies, I think in 2021, it was extended to 5-year data showing its durability.
Okay. What is the role of Eurolift in patients with retention?
Again, that has been proved by, I believe, Rochester's team, by Rochester's team, I believe. Just forgot the study, but it can be done in acute urine retention patients.
Okay.
That was done by just the team.
Okay. What complications can happen with the urethral lift?
That can be divided into general and specific. General happens majority of operations, which is problems with the anesthetic, pain, infection, bleeding, because we are doing some intervention. And specific for this procedure, you can have early, we can divide that into early and late. Early being hematuria, lasting for a few days to a few weeks, dysuria as well. And then long-term effects is requiring retreatment up to 15%, and also regrowth requiring further procedures, so failure of the procedure. There's also incrustation of the instruments, leading to stones and further procedures, and it's potentially migrating if it was not placed properly.
Okay. In real life, let us assume that you are doing a prostatic urethral lift for this patient. Just for the discussion's sake, what do you know about intraprostatic injections?
So intraprostatic injections, if it was if it as per Eurolift, I would say that it's associated with bleeding and infection, and it's important to know the size of the prostate before undertaking such procedures. If you were considering injections such as Botox into the prostate, that is not recommended as per to EAU and NICE guidelines, and that's old data.
Okay. What do you know about the procedure iTind?
iTind is a new minimally invasive procedure, the evidence of which is low evidence. I think the evidence was populated by Porbiglia in Italy, and they did prospective trials showing its efficacy. It improves Qmax by about 40%, I would say 30 to 40%. It works by using three sprungs, placed into the prostatic urethra, kept for at least 5 to 7 days and removed, all under cystoscopy, whether that be rigid cystoscopy. By placing the stent, the urethral stent, into the prostatic urethra, it causes pressure and pressure necrosis, and therefore improvement and opening up of the urethral channel.
Okay.
As I said, it was populated by the Corbiglia prospective trial study, no trial.
Okay. What do you know about the prostate stents?
Prostate stents are no longer used as recommended by NICE. The last thing I would say is that with regard to all these things, that there is a new study coming endorsed by Newcastle, which is the premise study, telling us which works better. And they are randomizing recruiting for TYP versus iTind, Rezum, and Urolift. And hopefully that'll be able to give us more information.
Okay. What is the role for the prostatectomy, simple prostatectomy?
Simple prostatectomies, as per GIFE guidelines, are recommended for patients, or can be an option for patients with 80-gram prostate or above. Again, simple prostatectomies can be done, I guess, if there are any contraindication for the other options. Ordinarily, people would do it with an open cystostomy route, either retropubic or Millen's fashion. However, there are some centers out there that are using a robotic approach.
Okay. Regarding the Rezum, what is the mechanism, how it works?
Rezum is a form of vapor therapy. It's been licensed as per the Gilling team in the McVary team, and it works by using steam ablation to the prostatic tissue. It's performed by using under rigid cystoscopy, particular equipments, needle with an open channel. It's inserted into prostatic urethra, depending on the size of the prostate, and depending on that will dictate how many injections in the prostate. Each injection lasts 9 seconds, and again, that's repeated depending on the length of the prostate. Small side effects. Again, efficacy is quite good as per the McVary trial, and improves Qmax by about 40 to 50%, with retreatment rates, again, roughly similar to Urolift by the name of 15%, 13 to 15%.
Okay, your time completed now. How do you think you did?
I think I waffled a bit. I think I didn't answer the question a few times.
I mean, it's not bad, but we are just starting first time, so it takes some time for us to settle down with the flow, etc. But the quality of answers are quite good. I am not concerned with the quality of the answers, but still there are some small space to improve, because this area is such a fast pace, moving area, a lot of changes happening, and also very packed with lot of values and names, etc. And I'm glad that you brought in the rope study, which also not very good in showing the long-term management for the prostatic artery embolization, and also various systematic reviews and meta-analysis also showed PAE is not super duper. So at least from urologist point of view, we should not encourage it. We should not lose the prostate surgeries to the intervention radiologist. Regarding Urolift, I'm happy for you to mention it like it's a procedure which can be done under local anesthesia. Nothing wrong in it. As you know, few people are doing it, but not everybody is doing it. It's only like, I will say, less than 5% of the actual Urolift surgeons are doing it completely under local anesthesia. Many use at least sedation or just LMA anesthesia, etc. So don't get fixed to LA. And I wish you to bring NICE guidelines, because NICE is working very hard to bring individual medical technology appraisal, MTA types of leaflets. The easiest way to remember is for Urolift and iTind, both it's September 2022. Both came in the same month. And so remember few here, for example, Rezum is June 2020, slightly older. And again, regarding the information leaflet, we have for Urolift, we have information leaflet. For resume, there is no information leaflet as such in the our bows.org website, but the guys in charge for resume, they have already prepared the leaflet. I think it's in the process of just committee review, etc. So we should be able to
I think it was a
see.
resume BAUS, actually. I forgot to say. It was BAUS. There's a resume leaflet on BAUS.
Yeah, but the leaflet was absent for resume for a very long time, and just now it started appearing in the Bows leaflet. But for Eurolift, we always had the leaflet. And yeah, premise study, as you said, Newcastle is a good one. It's a four arm study, which, if successfully completed, will give us a lot of idea about which arm is not doing well. And regarding the retention, you should be able to bring the name of the study. Of course, you can mention it like Rochester et al., but the name of the study is Pulsar. It is,
Yeah.
even though it's an old study, it was published as abstracts in EAU, AUA, and BJUI at least 2 years, if not 3 years back, subsequently. But actual publication happened only last month in BJUI campus or focus, something like that. So September BJUI last month, as far as the actual full article publication is concerned. So I think you did well. I have no concerns. Sometimes the examiners will be more than happy to discuss the monopolar and bipolar TURP. So just be confident in those things also. The other thing which we missed is aquablation. Aquablation has got again nice medical technology appraisal. There are studies like Water 1 and Water 2 studies. Maybe next round, if you're doing the BPH again, we can do aquablation bit in detail, because it can branch out anywhere. So that's why, as I asked, sometime the examiner, instead of asking you what are all the energy sources available, where you will be discussing 6-7 energy sources parallelly, the examiner will say which one you prefer, and so you can prefer whichever you want. So in your hospital, by chance, if aquablation is available, nothing wrong in choosing it, because not many students will choose aquablation, and it can give you quite good mark. And NICE has released the MTA appraisal for aquablation January 2023. And as I said, when I post the video, there will be in the background, you will get all the NICE guidelines, month, year, details, everything. So pause the video and you can follow it quite easily. Any other questions before we conclude today's session?
I think Anka has a question, but I was just going to ask, how would you describe Eurolift? Just one more time. And is there any other prostatic urethral lifts? Because it says prostatic urethral lift in GIRFT, but I don't know anything else other than Eurolift.
No, regarding the Eurolift, if you want studies, the NICE guidelines, as I said, September 2022, that has most of the things, and you are quite correct in the components of the Eurolift. Prostatic urethral lift evidence starts from lift study, and then we have the BPH6 study. I think you mentioned both of them. And following that, we had a few Cochrane review in May 2019, which compared whatever publications available till then, and mid-lift study for the median lobe. So any median lobe less than 1 centimeter and compressible, it is suitable for the Eurolift. And mid-lift study came in 2019. And as I said, Pulsar study for acute retention September 2023 last month. And I think Eurolift, this is enough. And if your question is like, how will you explain Eurolift to the examiner? If the examiner asks you Eurolift, of course you need to say Eurolift, there is no other choice. But if the examiner gives you the open choice, explain any one of the minimally invasive treatment. If you are comfortable with Eurolift, nothing wrong in starting them, because it has got, like, you know how the mechanism it works, and components of Eurolift, and there are a good amount of handful of studies which you can bring in. As much of factual information you bring in, that gives you good amount of mark. So imagine like this: 1/3 of the mark is for factual knowledge, like as you mentioned about the Rochester et al. Study, Pulsar study, all this factual knowledge, which is quite difficult, which is the most hard work part of the whole preparation. That's where you are working and, I will say, burning the midnight oil, whatever. The second one is the actual flow, which I think I don't have no concerns with any of you. The reason why we are giving importance to the flow is, in the essence, After finishing the FRCS exam, you will be suitable for a year one consultant. So we want the year one consultants to be good in communication with the patients, with the team, etc., etc. So that's why the communication flow, which usually is not a concern for UK exam goers, maybe a concern for some international people. The third one is the actual application of knowledge in clinical practice. So, as I said, if the examiner's question is choose any one of the minimally invasive treatment and explain how will you do, the patient's prostate is 60 cc. So, no way you can choose a simple prostatectomy, isn't it? So, it's good you are choosing the correct one and you are applying the knowledge to the patient. So, if you are choosing like Resume or Eurolift or iTrend, they're all quite good, including to URP, of course. And similarly, the previous one, 49-year-old, even though prostate is 60, the candidate correctly mentioned that I will try not to put the patient on dual treatment, even though NICE guidelines may say any prostate more than 30 cc, we need to start dual treatment, but I will try to see whether he's happy with tamsulosin alone. Fair enough. That's where the third one by third part of the application of the knowledge comes into play. So factual knowledge, which you can just read, spend your time within four walls, you don't need any help, you just have to memorize things like these drawings about the Abraham Griffiths number, etc., etc. They're all factual knowledge. The second one, communication, which usually won't be a factor, but if the other two factors may affect the scoring in the communication also. The third one, application, is more important. That's where your actual clinical supervisor or your these kind of sessions where we can help you to say exactly how to bring out the knowledge which you are reading. That's why this kind of Viva sessions will be useful to see how you are presenting it in a very methodical manner, not unnecessarily going towards unnecessary danger areas, etc. But otherwise, today all four of you did well, but I've given appropriate feedback then and there, and the usual format is exactly 10 minutes, but we can finish the answer if it goes above the 10 minutes, and we'll give the feedback then and there, and I will send you the recordings also as soon as it's available. Any other questions before we conclude today?
I can't see you recording. That's the last thing.
Yeah,
Unless you're recording.
I'm doing it in the background. Yeah, I don't do it in the
Oh, okay.
Zoom. The Zoom recording is not of good quality. Don't worry.
Understood.
Okay.
Thank you.
Yeah, go ahead.
Mr. Dhanasekaran, just a quick question, I think, which you answered. Regarding the median lobe, you said if it's above 1 centimeter, it obviously causes problems. But if it's under 1 centimeter, then it can be managed with the Eurolift.
Correct. Yeah. So MedLift study said that the median lobe should be the exact terminologies again. So when we are saying this, if you bring some terminologies that ticks you in the factual knowledge component, the actual terminology is intraprostatic enlargement. If it is less than 1 centimeter and if the median lobe is compressible, MedLift will give good outcome. Again, we should make sure that even for median lobe, we should not fire at 6 o'clock because of the danger of injuring the rectum. The median lobe should be carefully compressed and fired maybe around 3 o'clock or 4 o'clock so that it is nicely pinned down. And median lobe usually takes 1 or 2 implants to give a nice opening. If the median lobe is more than 1 centimeter, or if it's like a ball valve type, they are all contraindications for Eurolift. This can be decided based upon the pre-operative flexible cystoscopy assessment.
Sure. One further question I had was, it may not be relevant, but a person's risk for potential prostate cancer and having histology available at the time of doing bladder outlet procedures, would that influence or sort of guide towards what type of bladder outlet procedures you do? Because certain outlet procedures don't have any tissue available and some do. Therefore, analysis of that can yield certain pathologies, and that might dictate or further management of that patient. So would that influence your decision or not really in the era of MRI?
Yeah, I will answer this question in 2 prongs. The first one is it necessary to choose the procedure based upon the patient's possible high susceptibility to prostate cancer? Say sometimes if the PSA is slightly on the higher side, you may
Yes.
have, yeah, you may have done MRI which may come out as PIRAT 2, because if your PSA is on the higher side or PSA is abnormal, you will certainly do MRI, and if the MRI shows suspicious PIRAT 4, PIRAT 5, the whole discussion will go in a different angle. You will do a transperineal, maybe historically transrectal prostate biopsy, and then take it forward. But the question comes if the PSA is just below the higher normal, and if your MRI is also okay, like PIRAT 2 or something like that. And the answer is performing TURP with a view of getting histology to rule out prostate cancer is absolutely wrong practice, because in EAU guidelines it's quite clearly mentioned that don't do TURP with a view of getting the histology to prove or disprove prostate cancer, because we know that prostate cancer is predominantly a peripheral zone disease. In TURP, even though some good resectionist will go capsule to capsule 360 degrees, there is always a chance of leaving a good chunk of peripheral zone. So doing a TURP for the purpose of getting histology is a wrong practice according to EAU guidelines. The second thing, as you know, the procedures like ITIN, Eurolift or Resume or aquablation, they don't give any meaningful histology. Even though in aquablation you can get a kind of a gluey stuff which you can send it for histology, but it's very very rare to find a good meaningful prostate cancer diagnosis with that slush whatever we are getting from aquablation. And the other questions could be like if a patient has high chance for prostate cancer, maybe like Afro-Caribbean in origin, or the father or uncle or any other significant family history, etc. When you are doing Eurolift, you should counsel the patients. Number one, the patient should be aware that doing the Eurolift and subsequently if the patient's PSA became abnormal and if he required an MRI, there is a possibility that the implants can cause the like a heart beaming effect, like any other, like a hip prosthesis or something like that. So we may not be able to image a small part of the prostate where the implants are present. That is one thing. The otherwise it should not affect other pathways, like for example the rest of the prostate can be nicely quantified, and if the patient has PIRAT 4 or 5, doing a transperineal biopsy is quite straightforward. Transperineal biopsy not supposed to disturb the PET sutures. And then by chance if the patient unfortunately found to have prostate cancer and heading towards say radiotherapy, the Eurolift's capsular nitinol tabs will help as a fusidial marker, so there is a small advantage of it. And there is a study by name CoStar, which is a randomized study of patients awaiting radiotherapy for known prostate cancer, proven prostate cancer, but with significant LUTS. They are randomized to channel TURP and Eurolift. So we are waiting for the results. I'm not surprised if that study, the study name is CoStar. I'm saying again because it is not in the slide. And I'm not surprised if the study showed that Eurolift is good, because already these patients are on say bicalutamide for the first 4 weeks for flare symptoms, and also LHRH injections were given. So these itself modify the gland, and along with that in the future if they are getting towards radiotherapy, that combination itself can cause good amount of result. So there is a good possibility the CoStar study will come out with a recommendation stating that if a patient is heading towards the radiotherapy by histologically proven prostate cancer, if he has significant urinary symptoms, or the patient has got a catheter because of acute or retention or some episodes like that, then Eurolift is equally a good option compared to channel TURP. I hope that will be the outcome, because apart from Eurolift, apart from channel TURP, there are other factors which are also helping in patients' urinary symptoms. So this is another thing for linking prostate cancer with the benign diagnosis, etc. Yeah. Any other questions?
Thank you very much.
Good. And let me stop the recording now. The next scenarios will be on andrology. I will post individual messages on the date and time. And thank you for everyone joining today.